We'll get started. I have the extreme pleasure to introduce Dr. Priya Kathpalia. She's our fearless leader, gastroenterologist and medical director of motility at UCSF Health. She specializes in esophageal motility disorders, GERD, EOE, and other complex foregut conditions, utilizing advanced diagnostics. She earned her medical degree from Loyola University, Chicago, completed her residency and chief residency at Loyola University, and her GI fellowship at UCSF, where she received her advanced training in esophagology. She is our program director for UCSF's GI fellowship and is active in national professional organizations, including AGA, ACG, ASGE, and the American Foregut Society. Welcome, Dr. Kathpalia, and take it away.
Thanks, Afshin. Okay. Well, I'm excited to discuss esophageal manometry today, a topic near and dear to my heart. So let's get started. Hopefully, by the end of the talk today, we would have reviewed the type of equipment required for manometry, recognized key indications, discuss what constitutes a normal swallow. We'll review the Chicago classification as well, understand various clinical applications. We'll go through some cases, and we'll also discuss some limitations of high-resolution manometry and the advent of endoflip as well. So first, a bit of history. The esophageal manometry was actually invented in the 1950s. And they tried doing this even as early as in the 1800s, but the technology was just not there. And we have really improved the catheters such that they can really assess for lower esophageal sphincter localization. There is a lot less concern about artifact affecting studies. There is minimal need for calibration, so easier for our nursing staff, and lower maintenance overall of these catheters. The manometry catheter itself is a solid state catheter that spans the pharynx to the stomach. It has 36 sensors that are placed 1 centimeter apart. And around the lower esophageal sphincter, there's even less than a centimeter that these sensors are spaced. The catheter is positioned at the upper esophageal sphincter, and as I said, it spans through the lower esophageal sphincter. And just to give you perspective, the original catheters just used to be 4 sensors every 5 centimeters. So we've really come a long way technologically. Now, we always tell the patients to be NPO for at least 6 hours before the procedure and to avoid medications that could potentially interfere with the test. So we tell them to discontinue all pro-motility agents such as Reglan, prucalopride, domperidone, erythromycin, sedative meds, various blood pressure medications that can impact smooth muscle function and can interfere with testing. So we have a pretty extensive list of meds that we do review ahead of time with the patients and make sure that they stop that. And if they can't, we just make note of that and interpret that the test accordingly. After calibration, the catheter is passed transnasally. So you can imagine the minor side effects might include some epistaxis or sore throat. And rare but more serious side effects have happened, such as vasovagal episodes, bronchospasming events, and even aspiration events. Have not, thankfully, seen any perforations occurring from a mano catheter. That would be a really aggressive placement. But even if a patient has a large diverticulum, for example, the likelihood of perforating is quite low. So after the catheter is placed, there is a brief period to allow patient acclimation. A baseline resting pressure is really required to understand where the various landmarks are. And this 30-second period is the resting landmark. So the patient does not swallow and they're breathing normally. And there are times that it can be challenging for us to understand what's going on in terms of motility. So we might have the patient do various protocols depending on what their symptom presentation is. But in general, they are required to do 10 swallows of 5 cc's of liquid in the supine position. And then provocative maneuvers entail additional swallows in the upright position. But like I said, depending on what we're trying to do, we may try to stress the esophagus further and give them crackers or applesauce to try to bring about a motility disorder. Now, we do want to make sure that we verify that the distal sensors of the catheter are in the stomach. So we have the patient take in a deep breath, and this allows us to confirm that the catheter is through the diaphragm. And we want to identify the pressure inversion point. And this is the point where the pressure changes. Uh, 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 the negative intrathoracic pressure associated with inspiration inverts to the positive intra-abdominal pressure. So this is usually the pressure inversion point, often coincides with where the lower esophageal sphincter is. So let's briefly discuss indications and contraindications to esophageal manometry. So question for the first years, uh, Royce, I see you on here. Do you want to tackle this question? So in which patient might an esophageal manometry study be helpful? In a patient with an esophageal stricture on endoscopy, what do you think, Royce?
I'm leaning a little bit more towards B, in someone who's had workup that excluded like very overt structural causes, in which I would want to look for more motility.
Perfect. So B is correct. There's more than one answer here potentially. Let's ask one of your colleagues. Sean, are you on?
Yeah, I'm here. I would say patient E, um, the chest pain could be from like esophageal spasms that could be evaluated on
Perfect.
manometry.
Perfect. Perfect. Great. And the key there is just making sure that they have that negative cardiac evaluation before you start looking for spasming. Okay. And any other answers? There's one more. Is Karina on? Quentin, you there?
Yeah. Um, so I wouldn't do it with C because that sounds cardiac.
Okay, good.
Uh, D, if they're having like symptoms that the hiatal hernia doesn't explain, then maybe yeah, do manometry.
Yeah, or maybe they're getting worked up for fundoplication.
Mm, true.
You want to make sure they don't have an underlying motility disorder. So D is correct as well. Great. And you don't want to do this in somebody who has a stricture because that's going to mimic achalasia on manometry. Okay. So we will review the role of esophageal manometry in various cases, but I think it's important to recognize that first and foremost, you have to make sure that you do an endoscopy and that they don't have eosinophilic esophagitis, they don't have any strictures. Even if your suspicion is high for achalasia, we have been fooled, and so you really want to make sure you've done a structural assessment. Certainly in patients with non-cardiac chest pain, you can think about doing manometry as well, preoperative evaluation for fundoplication. And then if somebody is persistently symptomatic after surgery, you can also consider doing manometry, though the same criteria doesn't necessarily apply. The Chicago classification is really not geared towards patients who are post-fundoplication, and we'll discuss that briefly. Contraindications to manometry include uncooperative patients. Of course, if they're altered, you're going to have a tough time doing an unsedated procedure on them. If they've received any sedatives or narcotics, it can impact the study results. In particular, it can make the LES pressures look higher than they actually are. Now, if it's something that they're on chronically, then if they truly do have elevated LES pressures, you would treat that as a de novo condition potentially, but it's a case by case basis. So you really want to know if they're on it, if it's something they can stop, or is this going to be a long-term medication. And then if they have a history of sinusitis, you can, of course, worsen things with passage of the catheter. Patients with aspiration risk, you just have to be cautious, but it's not an absolute contraindication. All of our pre-lung transplant patients getting worked up for lung transplant, are getting manometries placed, and their aspiration risks are quite high. So in those patients, we might alter their protocols. We might not do supine positioning. We may do upright. It's not one size fits all. We kind of have to think about the clinical scenario. So as you may know, all of our manometries at UCSF are done with impedance testing. And impedance monitoring works by using an alternating current generator to apply an electrical potential between pairs of metal electrode rings that are separated by this isolator. And the electrical current loop can be closed through conduction of electrical charges by the surrounding material that's bridging these two metal electrode rings. Air, liquid, esophageal mucosa have unique impedance characteristics, and so they allow the definition of which material resides between each pair of electrodes. Air is very resistant to current flow and so has a high impedance value, whereas saline or gastric contents have relatively low resistance to flow and so have low impedance value. Esophageal mucosa itself has an intermediate impedance range and so serves as a baseline during monitoring. So why do we add impedance testing to high-resolution manometry? Well, we use it in conjunction with HRM to really assess transport function of the esophagus or bolus clearance. We want to understand how bolus transit relates to relaxation of the LES. And if bolus transit abnormalities are found, it may help define disease states and direct clinical treatment. So, like I said, we do it with 100% of our manometries. It's built into the catheters that we have here. So let's briefly discuss the anatomy of the esophagus and normal swallow patterns. So functionally, the esophagus can be considered divided into three zones. We have the upper esophageal sphincter, which is tonically closed and contracts during inspiration to prevent air from entering into the GI tract as well as reflux. And it relaxes during swallowing, belching, and vomiting. We then have the esophageal body, the cervical and the thoracic esophagus. And then we have the lower esophageal sphincter, which maintains a steady baseline tone of around 20 millimeters of mercury to prevent gastric contents from entering the esophagus. The LES also contracts during periods of increased intra-abdominal pressure to try to prevent reflux from occurring due to pressure buildup in the abdomen. It's important to recognize that the LES is actually a 2 to 5 centimeter circular muscle layer. So it's not just 1 centimeter. And knowing that is important when you're doing things like Botox injections, that you don't have to just do them right at the LES, and going just proximally may help you capture more benefit. So there are 4 layers of esophageal tissue. Just outside the lumen is the mucosa, then you have the submucosa, then the muscularis, and then the adventitia. The muscularis has 2 muscle layers, the inner circular layer as well as the outer longitudinal layer. And the longitudinal muscle tends to shorten the esophagus, while the circular muscle is what forms the lumen occluding contractions. And so it's this combination of these localized contractions that is ultimately responsible for peristalsis. As you know, the proximal esophagus contains the striated skeletal muscle, and then the distal esophagus has predominantly smooth muscle with this long transition zone between. I just show you this figure to show that swallowing is a complex process based on the location of the esophagus and the muscle type, and it consists of both parasympathetic and sympathetic nerves. So let's move on to the Chicago classification. True or false, the Chicago classification was originally developed in patients with dysphagia. Let's see. Looking for some first years. Maddie, is Maddie here?
I'm here. I'm just gonna take a wild guess and say true, but based on no information.
Does everyone agree? Okay, it's actually false. So just a piece of trivia. It was actually developed in healthy volunteers at Northwestern, many of them who were medical students. So the first official classification system, I should say that probably wouldn't happen in this day and age, but it was first developed in 2008, and then it was revised in 2012, and most recently in 2020. So high resolution esophageal manometry is now the new worldwide standard for the clinical evaluation of motility disorders. And I think it's really revolutionized this field. The first thing to recognize is that time is on the x-axis and the esophageal position is on the y-axis. And warmer colors tend to represent higher pressures, lower pressures are colder colors. And then the top bar is where the upper esophageal sphincter is. And then the bottom bar represents the lower esophageal sphincter. And you can see it opening here to allow passage of the bolus into the stomach. So this, again, is a figure showing high resolution manometry. X-axis indicates time, Y-axis indicates location from oropharynx to the stomach. And below you can see a schematic representation of esophageal motor activity during a swallow. It is a computer-generated automated analysis of the study, but really ultimate interpretation needs to be performed by an experienced and competent clinician in this. And I can't tell you enough how many times if you just look at the PDF of the study, you're not going to get an accurate representation of what's going on. I think it's important to recognize that the software can easily interpret normal studies, but when there is pathology, there is a lot of variability on understanding kind of where you place the markers and some nuances that the computer can't seem to pick up. So they've actually been trying to use AI to help physicians decrease their workload by interpreting these studies. But unfortunately, there's so many nuances that it's not nearly ready for prime time. Hopefully one day, though. Here again, you can see the upper esophageal sphincter is opening. You have a nice peristaltic wave and then LES relaxation here. The top 1/3 of the esophagus is skeletal muscle. The bottom 2/3 is smooth muscle. And then you have this transition zone. So that's why you tend to see a little bit of decreased pressure within that transition zone on these swallows. So let's briefly discuss some of the landmarks on manometry that will help you better interpret these studies. So first is the IRP, or the Integrated Relaxation Pressure, which measures EGJ pressure or deglutitive EGJ relaxation over a 4-second period. So the resting LES pressure, the basal LES pressure, gives measurement at one point in time, but the IRP is expressed as a median of the 10 test swallows in millimeters of mercury. So just remember that that's a board's question, that it is the median of the 10 swallows. And a normal IRP value is less than 10 to 15. It used to be 15, but there are lots of cases of evolving achalasia in this 10 to 15 range. So in the most recent Chicago classification, this IRP has been changed to 10 to 15. Then you have the CDP, or the contractile deceleration point, which is the inflection point along the pressure contour where the swallow tends to slow down. So in other words, this represents the transition from esophageal peristalsis to emptying. And then you have the distal latency. So the distal latency is really the time between when the UES opens to the CDP, to this deceleration point. And this helps us to evaluate for premature contractions. And this is the basis for defining distal esophageal spasming, as well as potentially type 3 achalasia. It's one of the criteria is to have this spastic component. So normal distal latency tends to be over 4.5 seconds. And then you have the DCI, or the distal contractile integral, which is a multiplication of amplitude, length, and duration of the contraction. So it's actually reported in millimeters of mercury times centimeters times seconds. So in other words, I tell fellows when I'm working with them to think of this as the peristaltic vigor, or how intense the contraction is. And each of these parameters are measured for each individual swallow. So a normal swallow, or I should say a hypercontractile swallow, tends to have a DCI of over 8,000. A weak swallow is under 450, and failed is under 100. So normal is between this 450 and 8,000 range. Each of these parameters are measured for each swallow, and it's most important to first start with understanding the lower esophageal function, and then looking at the esophageal pressure patterns to classify each patient. So this is the Chicago classification, which is based on information from each of the individual swallows. And you can see, again, it's the LES function that, or the median IRP, that helps us to distinguish disorders of outflow obstruction from disorders of peristalsis. So if the IRP is normal, then you're going to start thinking about disorders of peristalsis, which could include absent contractility, spasming, hypercontractile esophagus, or ineffective esophageal motility. And then with regards to outflow obstruction, those could be either achalasia patterns if they also have failed peristalsis, or if the peristalsis is normal, then you may have something called EGJ outflow obstruction, or esophagogastric junction outflow obstruction. So that's where you have normal peristalsis, but an abnormal median IRP, an elevated median IRP. Now, with outflow obstruction, you do want to do some sort of confirmatory test, whether it's a timed barium esophagram or an endoflip, to confirm this finding across the EGJ before you confidently say it is this. So if we see this on manometry, we may ask our providers to get a confirmatory test. So the primary dividing point in the Chicago classification that helps us to distinguish achalasia from other motility disorders. Is Vincent here?
Yep. Um, I think I think the LES relaxing seems to be important.
Exactly. Just making sure everyone's paying attention. So whether or not the LES relaxes is really what helps us understand if, is the IRP elevated, And that is the dividing point, as we just discussed, for achalasia versus disorders of peristalsis. Okay, so let's move on to some clinical applications. So we have a 65-year-old female with a history of hypertension and hyperlipidemia. She presents with 6 months of episodic vomiting, dysphagia, difficulty swallowing, initially with solids, now to solids and liquids. And she also has some atypical chest discomfort, has had a negative cardiac evaluation. She's lost 15 pounds in the past 3 months, and she denies any alcohol or tobacco use. Before coming to us, she's already had a barium esophagram, and here you can appreciate the bird's beak narrowing distally due to the contracted lower esophageal sphincter, and you can see where it gets its name from, which is classic for achalasia. But it is important to make sure that there is no stricture or anything else that may be or a mass that could be mimicking some narrowing at the distal esophagus that can make the LES pressure seem high there. So this patient underwent an upper endoscopy, and I should mention, when you are suspecting achalasia in a patient, we often will tell the patients to fast for a longer period of times or to be on clear liquids at least for the day prior, so that we aren't spending several minutes doing a food disimpaction before we actually get to see what's going on. So she has some retention of food debris and liquid here. The esophagus tends to be windy or tortuous before we get to the GE junction in this case. And as we traverse the LES and go into the stomach, we feel a popping sensation due to the contracted LES smooth muscle. So the LES can appear puckered, but it may it may or may not open with air insufflation. In advanced cases of achalasia, it may not open. But I should mention that you can have an entirely normal endoscopy and you could still have achalasia. So just because you don't see these signs, which are often signs of more advanced or long-standing achalasia, doesn't mean that you shouldn't think of this condition. So anybody who has dysphagia and normal endoscopy, negative esophageal biopsies, you really should think about doing manometry. For this patient, high suspicion for achalasia at this point, she undergoes manometry, and this is what we see here. I'm just going to put a normal swallow here. So I'd love for one of our senior fellows to walk us through this. Any volunteers, senior fellows? Don't be shy.
You know, I struggle a lot with manometry, so I'll just learn with you.
Sure.
So I'm seeing down my screen. I can't see the bottom half, but I think IRP was elevated at 20. So it's, it automatically goes to that left wing of the Chicago
Sure.
classification. So patient may have achalasia versus EGJOO.
Okay.
Distal latency is 3.2 seconds, which normal is less than 4.5, so meets criteria.
Perfect.
I think that's all I have right now.
Okay. So what kind of achalasia is this if it's the distal latency is short?
Um,
You can phone a
Type
friend.
3.
Type 3, exactly. So perfect, Afshin, thank you. So this is a type 3 achalasia pattern. Of course, this is a representative swallow, and you're going to want to see this consistently throughout the 10 swallows, which usually you will. So this is type 3 achalasia, where at least 20% of the swallows should be premature. So achalasia is derived from the Greek word kalasis, which means not loosening or relaxing. The incidence of this condition is 1 in 100,000 worldwide, but it seems like we see it with so much frequency these days, probably a bit of a skewed population in some of our clinics. It is associated with loss of the myenteric plexus ganglion cells in the distal esophagus and the LES. And there are various theories. One is that perhaps it's an autoimmune process that's triggered by an indolent viral infection in somebody who's genetically susceptible. And we do know that patients with achalasia tend to be more likely to have a concomitant autoimmune disease than in the general population. And the prevalence of autoantibodies tends to be higher, though certainly we're not checking for that when we see these patients. The one theory that we do know is true is that they could have Chagas disease, which is due to the parasite Trypanosoma cruzi. And I should also mention that even if you do have Chagas disease, the treatment for it is not necessarily going to be different, but it's important because it can impact other organ systems. So here are the most common symptoms listed that may prompt a referral for a motility evaluation after, of course, the common conditions are ruled out: GERD, mechanical obstruction, such as strictures or rings, or malignancy. And the hallmark is progressive dysphagia to both solids and liquids that we see in about 90% of the patients. But it's not uncommon to see just heartburn in these patients, and maybe they don't have dysphagia. You have to remember that some of these patients could have had symptoms for so long that they're kind of immune to them, or they've adapted to them. They're chewing their food really well. They're drinking water to facilitate passage of the bolus, and they don't even realize it. You can see regurgitation or vomiting, non-cardiac chest pain, epigastric pain, and then in some patients, just adynophagia. Now, respiratory symptoms are also not uncommon because there could be some microaspiration that's occurring in this population. But dysphagia tends to precede the respiratory symptoms by an average of 24 months or so, which really indicates the kind of progressive nature of symptoms with lack of treatment. And the average symptom duration at the time of diagnosis is actually 2 to 5 years, which is kind of sad. So a lot of times these patients who are younger, for example, may be chalked up to just having GERD. But we have to have a high clinical suspicion in patients with dysphagia and negative endoscopy. And I will say that it can happen at any age. So just recently at Children's Oakland, there was actually a 6-month-old baby who had achalasia. So achalasia requires a combination of testing to come to the diagnosis. And esophagram tends to be performed by a primary care provider even before referring the patient to our clinics. But if it's not done, sometimes we might perform it side by side with manometry to confirm the findings. Or if manometry is not as clear cut, then we might use an esophagram with a barium tablet in that setting. And I can't stress enough how important it is to do the endoscopy before doing the manometry to rule out erosive reflux disease, eosinophilic esophagitis, structural lesions, malignancy. And sometimes in these patients, you can see candida as well, and that's just from the stasis of food and liquid. And I think it's also important to recognize that in patients who have candida who are immunocompetent, you should think about an underlying motility disorder in them, even in the absence of dysphagia. And then endoflip we will discuss briefly today, but it's a helpful test when manometry is inconclusive, or maybe you have outflow obstruction, peristalsis is normal, but you're still suspecting some sort of evolving achalasia pattern, then endoflip can be helpful. The treatment is aimed at reducing LES pressures, increasing emptying of the esophagus. But it's important to remember that there is no cure for this condition, and return of peristalsis is highly unlikely. So the two treatments that tend to last the longest are myotomies and pneumatic balloon dilations. Botox and use of nitrates or calcium channel blockers are really not all that effective. Botox is okay to use sometimes in patients who maybe aren't candidates for more definitive therapy, who have limited life expectancy, or maybe they're acute, they're admitted to the hospital and they are, need immediate relief. Even if they haven't had the manometry, but you have a high suspicion for achalasia, you could consider Botox. But the definitive therapies are myotomy or pneumatic balloon dilation. And what you offer the patient really depends on your institutional expertise. So some centers are all about doing graded pneumatic balloon dilations. Here at UCSF, we really have tried to emphasize myotomy. And thanks to Dr. Kawanda, he does 100% of our poems at UCSF, and he's doing about 2 a week. So these days, we actually aren't sending many patients for Heller. We tend to send them more for poem, given the minimally invasive nature. Though we will present all these options with the patient and have a discussion on what might be the best approach. So moving on, a similar patient, 65 years old, hypertension, hyperlipidemia, has 6 months of episodic vomiting and dysphagia. Again, difficulty swallowing with solids and now to solids and liquids. Also has some atypical chest pain, has had some weight loss, and denies alcohol or tobacco use. Had an esophagram. And again, has some narrowing here. The radiologist comments on some shouldering in the distal esophagus. Ends up having an endoscopy to rule out any stricture or malignancy, and don't really see anything. But even with careful evaluation of the distal esophagus and the cardia, you can miss a tumor in about 1/3 of these patients because of submucosal growth. And so just because you do biopsies of the GE junction that are normal doesn't mean that they don't have something submucosally. So if there is suspicion of malignancy, like in this patient based on the esophagram findings, then we may often recommend something like a CT scan or an endoscopic ultrasound to further evaluate the distal esophagus. So this patient undergoes manometry, and the IRP is elevated, but this patient has a normal peristaltic wave. And so this patient is classified as an EGJ outflow obstruction. And the patient undergoes a CT scan because of the high clinical suspicion for malignancy, and unfortunately has a large mass in the lung that seems to be compressing on the distal esophagus. So the differential for outflow obstruction is early achalasia, pseudoachalasia, like in this patient. Or no, I shouldn't. This patient has more of an outflow obstruction. There could be strictures or rings, paraesophageal hernia, or infiltrative process. And certainly could have some extrinsic compression of the LES as well. So again, consider CT scan or EUS to rule out extrinsic compression or an infiltrative process that can be missed with superficial biopsies. So some limitations of esophageal manometry. First, it's unclear how age, obesity, body position, and esophageal length can interfere with normative measurements. You can miss findings during a short period of testing, though conditions of major motility disorders are going to be present even if the patient is less symptomatic during the testing period. You have to correlate the findings with symptoms and imaging. And so sometimes this is challenging for us when we're reviewing manometries, where about 1/3 of our manometries are direct referrals from the outside. We haven't met the patient and they're just coming for the procedure. Sometimes interpreting the study does require some clinical correlation or understanding of the other studies that have been done. And so we have to make that clear to the referring providers when we're reviewing these studies. It is also easy to overcall diagnoses with the Chicago classification. And so that's part of the reason, as I alluded to in the most recent classification, they changed that IRP to the 10 to 15 range because people were getting overcalled with achalasia or outflow obstruction, and they they might have been in this 10 to 15 range, and it may have had more of a normal normal motility overall. UES abnormalities are not incorporated in the Chicago classification, and then post-surgical issues are not classified in the Chicago classification. So even though we often will do manometries in patients who are having dysphagia post-operatively, we have to interpret with caution. And now there are modifications to the Chicago classification that take into account fundoplication anatomy when evaluating those patients. So let's briefly discuss EndoFlip. So EndoFlip, FLIP stands for Functional Lumen Imaging Probe, and the catheter is placed transorally at time of endoscopy across the EGJ, the esophageal gastric junction. And it utilizes impedance planimetry during volume controlled distension of this balloon. And we are trying to measure the luminal cross-sectional area along the axial plane. And the standard catheter size is 240 millimeters with a 3 millimeter outer diameter, and there is this balloon mounted distally. There are 16 impedance planimetry electrodes within the balloon. And the main goal is really to measure the mechanical properties of the GE junction using volume controlled distension. So it's a stepwise volumetric distension of the balloon across the EGJ. So the utility of this, well, it provides measurements of the diameter and the cross-sectional area at various intervals at 1 intraballoon pressure. And simply, it's a real-time measurement of the narrowest area along the 16 recording sites. Indications for EndoFlip include that it is an adjunct to other diagnostic tools for assessment of dysphagia. So you don't want to rely just on EndoFlip in the evaluation of these patients. It is also indicated in patients who have dysphagia, who maybe have an inconclusive manometry. It can also be used in patients who have eosinophilic esophagitis if we're looking for subtle strictures or narrowing that we may not appreciate endoscopically because of insufflation. You might be able to pick it up on EndoFlip, and you can do more targeted balloon dilations in these patients as opposed to savory dilations. And then for intraoperative assessment, to tailor the length of the myotomy, you may want to do an EndoFlip so you know how long to make the cut of the lower esophageal sphincter and the distal esophagus in POEMS, for example. So Dr. Kawanda is doing these during his poem. He does it right before the poem and then before he closes up to make sure that he's had an adequate response. And if not, he can tailor the length further of the myotomy. So pretty cool technology overall, and certainly an evolving field within esophageal motility disorders. The most important thing to gain from an EndoFlip is the DI, or the distensibility index, which takes into account the cross-sectional area and the intra-bag pressure. So the CSA over the intra-bag pressure is what allows us to calculate the DI, and it is a computer-generated value that you'll get in real time when you're doing this study. Now, what's the relationship of manometry to FLIP? Well, this is a nice study showing the correlation of mano findings to distensibility index. And you can appreciate that in patients who have achalasia or outflow obstruction, or even a hypercontractile esophagus, tend to have a distensibility index of under 2. Normal tends to be closer to the 4 to 6 range. Patients with ineffective motility, a disorder of peristalsis, and not outflow obstruction tend to have relatively normal IRP, and so not surprisingly, their distensibility index tends to be in the normal range as well. So just some take-home points from our talk today. Remember to make sure you tell your patients to avoid promotility agents, various antihypertensives, and narcotics prior to the procedure. To confirm the distal sensors of the catheter are in the stomach by identifying that pressure inversion point. Recognize various indications for performing esophageal manometry, first and foremost with patients who have dysphagia and negative endoscopic evaluation. The Chicago classification system standardizes interpretation of these studies. First, the LES function and subsequently the esophageal pressure patterns are used to make a diagnosis. Patients with classic achalasia have aperistalsis and poor LES relaxation. There are various treatment options, though myotomy or pneumatic dilation tend to have the longest durable response. And we use a combination of radiologic, endoscopic, and manometric studies to make a diagnosis of a motility disorder. And clinical context really remains essential for understanding what do you do next in a patient with a motility disorder. And finally, EndoFlip can be used as an adjunct tool in patients with dysphagia. So we have a growing motility team here. I'm super excited that Shay joined our team last year, and then Allison Richardson is the newest member of our team who recently joined our faculty. So welcome, Allison. And then wanted to give a shout out to our nurse practitioner, Daryl, who started as our endoscopy nurse, then became a motility nurse, and then became our motility NP this past year. And then, of course, our nurses, Shane and Allison, and our administrative team as well. So couldn't do it without all of you. So thank you so much, and I'm happy to answer any questions that you have.